more apparent and more of interest really across care settings. And most of you on the call are aware of the various models that exist out there for coaching, and in particular, one of the models being Dr. Eric Coleman's model from the University of Colorado, the Care Transition Intervention Model. Today we have the unique pleasure to hear about how a home health agency has integrated the Coleman model into their agency work. We will hear how they have developed this idea, starting with the early stages of development up until today, with what they have been able to accomplish both in terms of benefits and outcomes, and also opportunities of improving patients' transitions across care settings and increasing a patient's activation. We're pleased to have with us today Tasha Mears and Beverly Taylor, both from Amedisys. Following Tasha and Beverly's presentation, we will have time for questions. We would ask, as you generate your questions and thoughts during the presentation, that you forward these questions to hhqi@wvmi.org. Again, hhqi@wvmi.org. We will utilize this format to handle questions given the expected large numbers of participants on the call today. I'd like to introduce both Tasha and Beverly. Tasha Mears is the Senior Vice President of Clinical Operations at Amedisys and is responsible for quality infrastructure. She first joined Amedisys in 1998 as a clinical director. Tasha holds 2 associate degrees and a Bachelor of Science in Nursing. Since 2008, Tasha has served as the chair of the Quality Working Group for the Alliance for Home Health Quality and Innovation. And in 2009, she was appointed by the Centers for Medicare and Medicaid Services as a member of their technical expert panel on care transition measure development. Beverly Taylor is a care transitions coordinator for Amedisys in Lawrenceville, Georgia. She's been with Amedisys for 17 years, and her career spans 22 years in nursing in both home care as well as hospital work. She is a distinguished member of the Amedisys Patient-Centered Care Team, having recently been recognized with various awards, including the company's Chairman's Club and President's Club Awards for excellent performance. Beverly has played a key role in the Georgia QIO Care Transitions Initiative. The format of today's presentation will be that Tasha will first provide us with a higher level overview of this initiative, and then we'll switch over to Beverly, who will talk to us about the local efforts of this initiative in Georgia. After Beverly is completed with her piece of the presentation, we'll turn back to Tasha for some closing thoughts on the great work that Amedisys is doing. Without further ado, I would like to introduce Tasha Mears.
Thank you very much. Can you hear me? Excellent. Again, my name is Tasha Mears, and we're very happy to be presenting on the webinar today. Our discussion today will focus on 4 points. First of all, what is care transition? Why is it important? And then I'm going to turn the call over to Beverly, and she's going to talk about her work with the Georgia QIO initiative that led us as an organization to really see the value and resulted in a nationwide rollout. And then last, I'm going to close with some insights and best practices that we found throughout the implementation of care transitions. So why is care transitions important? In March of 2009, the National Coalition on Care Coordination with Dr. Randall Brown did a study that indicated that small percent of Medicare beneficiaries with multiple chronic conditions account for the vast majority of spending, all too often due to the main areas of inadequate care, poor communication, and weak adherence by patients. And almost a decade of research and demonstrations have developed evidence regarding care coordination interventions that help resolve these issues. Dr. Eric Coleman defines care transition as the movement that patients make between healthcare practitioners and settings as their condition and care needs change during the course of a chronic or acute illness. For example, we might have a patient that has an exacerbation of the disease process and might be seen by their primary care physician, who later might end up in an acute care type setting, cared for by a completely different care team, and later might actually transition to home or to hospice or to home health or other outside provider for further care by a completely different team. Each one of these shifts from care providers and systems is defined as a care transition. It is actually during these times when the patient is most vulnerable and their informal caregivers are often overwhelmed. The systems of care fail the patient by not ensuring that the critical elements of the care plan developed in one setting are transferred to the next, and that essential steps that need to take place before and after the transfer are executed. Dr. Eric Coleman is quoted as saying, practitioners need to shift their mindset from the concept of a patient discharge towards that of a patient transfer to continuous care management. We truly are, in an acute care setting, they're a moment in time in the patient's life. And they have multiple chronic diseases that they will have to live with for the rest of their life. And the only common denominator in each one of these transitions is the patient. The 4 pillars of Dr. Coleman's health coaching model include a focus on medication self-management, follow-up physician appointments, a patient understanding of red flags and signs and symptoms, who to call when about what to get help, as well as a patient-centered record. We've also reviewed the work of Dr. Mary Naylor, who's a PhD RN at the University of Pennsylvania School of Nursing, who has also done work on care transitions. We reviewed her model as well, which was primarily nurse practitioner-centered, where the nurse practitioner would follow the patient to a doctor's visit, would see the patient in the hospital prior to discharge, had a certain number of home visits, but again was also focused on patient empowerment, working through their chronic disease processes. Dr. Stephen Jenks had an article that many of you are very well familiar with that was posted in the New England Journal of Medicine in April 2009 that further indicated the scope of the problem. Almost 20% of 11.8 million Medicare beneficiaries are rehospitalized within 30 days. 53% of those discharged from a surgical procedure are rehospitalized or die within the first year. And 50% of those rehospitalized patients had no physician office visit in between those hospitalizations. He also found out that readmissions tend to take a longer length of stay for the same DRG. So when they come back, they actually have to stay longer. Medical causes dominate the readmission rate, and the cost of unplanned rehospitalizations in 2004 was $17.4 billion. From the Care Transitions website, and this information was actually even posted in the Best Practice Implementation Package as a part of the Home Health Quality Campaign in January, it indicated that Medicare patients report the greater dissatisfaction related to discharges than any other aspect of care that CMS measures. And we're estimating that up to 76% of readmissions within 30 days of discharge may be preventable. So it's very obvious that CMS is targeting readmissions to the hospital within 30 days of discharge as a probable marker for both poor quality of care and money going down the drain. But as they weigh Medicare reimbursement cuts for readmissions, CMS is also investing in strategies to lower readmission rates to improve quality of care. Care transitions is one of them that they're looking at. So now I'd like to turn the call over to Beverly Taylor, our very first care transition coordinator, to talk about the work she did with Gwinnett Medical Center and the Georgia QIO project that kick-started this as a nationwide initiative for our company. Beverly?
Thanks, Tasha. Hi, everyone. I'm Beverly Taylor, a care transitions coordinator for Amedisys in Lawrenceville, Georgia. I've been a nurse for 22 years, and 17 of those years I've been a part of the Amedisys home health team. Before I joined Amedisys, I was a cardiac nurse for Gwinnett Medical Center in Lawrenceville, Georgia. My perspectives from being a nurse in both the hospital and home health settings have helped me tremendously in becoming a care transition coordinator. I am proud to have been a member of the Georgia Quality Improvement Initiative, what we refer to as the Georgia QIO, where we implemented the patient coaching model for congestive heart failure patients, which led to the national rollout of patient-centered coaching and care model at Amedisys, which we call care transition. The HHIQ has asked me to share my experience working with the Georgia QIO so that you may gain insight into how the coaching model works for Gwinnett. As Tasha mentioned, in October 2008, the Georgia QIO invited healthcare providers to come together to explore ways to reduce readmissions in the local hospital. Gwinnett Hospital took a proactive role and began forming a committee to look at why patients with congestive heart failure, which was their highest readmission diagnosis, kept returning to the hospital. The committees included hospital physicians, case managers, social workers, clinical nurse managers, utilization review nurses, the community assisted living facilities, personal care homes, and nursing homes, as well as representatives from Amedisys and Healthfield Home Health Company. It was evident that the input from the entire continuum of care in the community would be vital to the success of Care Transitions Initiative. Based on our collaborative analysis of Gwinnett congestive heart failure patients' data, the committee determined that the congestive heart failure patients were not receiving the optimum level of transition support and care when they left the hospital. Our hypothesis was if they did, perhaps avoidable readmissions could be prevented. To test this hypothesis, the hospital case managers began to identify patients with congestive heart failure diagnosis and incorporate home health into their discharge care plan and began implementing the patient coaching model starting in the hospital. Gwinnett began classes for congestive heart failure patients to begin educating them on their disease, as well as how to manage their congestive heart failure before they were discharged from the hospital. These multiple disciplinary classes were formed by Paula Thornburg, nurse manager, Cynthia McClendon, clinical nurse specialist, Dottie Merrifield, a clinician, and Sarah Kim, a dietitian. During the classes, they learned how to manage their congestive heart failure by identifying early warning signs and symptoms, following a low-sodium diet, and the importance of cleaning themselves regularly. They learned the various causes of congestive heart failure and how it affects their bodies. The home health companies reviewed their teaching tool with the hospital to ensure that the education continued to build on what was established in the hospital, but more importantly, that all patients receive the same standardized education through their continuum of care. One of the key challenges the committee identified was that patients were being readmitted for medication issues such as inability to afford medications, underutilization of medication, and not understanding the usage of each medication. To help manage challenges such as these, the hospital began to rely on home care teams to provide a multiple disciplinary approach, including social workers, to help integrate community resources into the patient's care plans, such as medication assistance. Physical therapy was also included in this approach to help prevent avoidable falls. The increase in diuretics caused physical weakness in some patients, which increased the risk of falls. So physical therapy and fall prevention was a critical component of the protocol. As the committee continued to meet each month and evaluate the effectiveness of the measures put in place to prevent avoidable hospital readmissions, they found that there were patients still returning to the hospital. It was determined that these patients were not weighing themselves daily, so they were not able to identify weight gain early and take action. And looking closer at this problem, we learned that the patients did not have scales in their homes and could not afford them. The hospital formed a scale foundation to purchase scales for patients who did not have the financial ability to purchase their own, which made a tremendous impact in their disease management. Additionally, the scale committee researched to find the most accurate scale while mindful of the safety concerns of the geriatric population. The committee determined the scales must have broad base, digital display, and memory recall. A standard was also developed that the patients must weigh themselves at the same time each day and record the information to be successful in the congestive heart failure program. These wonderful foundations led to all congestive heart failure patients receiving the weight management guide and scales information as part of the hospital discharge planning. Dr. Gangasani, a cardiologist for Gwinnett, also set forth a protocol to treat congestive heart failure patients at home in partnership with the participating home care providers. The protocol addressed weight gain and treating it with additional diuretics. The home health protocol included a predetermined number of visits to address weight gain and lab work to ensure the effectiveness of medications. The hospital physicians also set a standard protocol that all cardiovascular patients must have a follow-up appointment within 1 week after hospital discharge. All of these coaching model elements, the hospital care team together with their home health partners, led to great results. In 2008, the readmission rate for congestive heart failure patients at Gwinnett Hospital was 22%. With the measures it put in place, they worked actively with the home health agencies to form a team approach for managing these patients. Their readmission rate decreased to 17% in their congestive heart failure population. I am so proud of our work with the Georgia QIO, and I am privileged to live the coaching model every day as a care transitions coordinator for Amedisys. I see the impact it makes on our patients, their families, and their outcomes. Thank you for allowing me to share my story.
Thank you, Beverly. On a high level, on the next slide, what you'll see are some of the key points that we used when we kick-started this program with Gwinnett, working with the Georgia QIO. We extensively trained 7 locations surrounding the QIO that were in the contracted community in early 2009 when we started this. In April 2009, we launched our care transition program with primary partnership with Gwinnett Medical Center and all the details that you heard Beverly describe. We expanded the account manager role with additional training to a care transition coordinator, the key differences being more patient interaction, less of just a referral intake type position. But we also realized that all of that work, we needed to educate all of our field disciplines. So all of them were trained on patient self-management and health coaching. Initially, this program focused on CHF patients, but was later expanded to patients from this facility. What we saw in the Lawrenceville office on our side for our hospitalization rate that we're measured on by CMS is a 1% decrease in a year for that entire agency. In March of 2009, using that as our baseline, our hospitalization rate for that agency in totality was 32.8%. In March of 2010, a year after the implementation of this project, even just focusing on one facility, and at first just one set of patients with CHF, impacted the entire agency's hospitalization rate and decreased it down to 31.8%. So we saw this as an evolution opportunity for us as an entire organization. We had a team of over 400 account managers nationwide in various facilities. And we determined with these great results and the community coming together with Beverly's hard work that we had an opportunity to expand this initiative nationwide and create care transition coordinators across our company. So what exactly are the interventions that a care transition coordinator does? Once we receive the referral for home care, the care transition coordinator has an in-facility, face-to-face patient interaction. And the purpose of this interaction is to coordinate the transition to home care, initiate the patient health history and self-management record, promote physician follow-up visits, and start that medication reconciliation before the patient even steps out of the hospital. Key questions that we ask is, do you have a physician appointment for when you leave the hospital? Does your physician know you're in the hospital? Let's help make that appointment for you so we can ensure that you have follow-up even before you go home. What we realized is that we needed some tools for both our patients and care transition coordinators. So looking at all the self-coaching models, we created our Bridge to Healthy Living personal health planner for our patients. We start with providing this planner to our patients post-referral during that inpatient interaction with the care transition coordinator. We encourage the patient to complete as much of this as possible prior to leaving the hospital. Let's start with your diagnosis. Do you know why you're in here? Do you know what other conditions that you have? What is your current medication list? Often, as home care providers, when we finally get into the home, we realize that that medication list that was in the hospital may or may not mirror what the patient had actually been taking in their home. When is their next appointment? What are the key things that they need to know before they leave the hospital? That's their discharge criteria. That's their discharge checklist. And what signs and symptoms to report. This Bridge to Healthy Living pamphlet initiates and promotes patient self-management. But the key thing is that this continues throughout the course of care. It doesn't just stop in that first face-to-face interaction. Once the patient has gone through the admission process and meets all the criteria for full home health admission, we have some intra-episodic interventions that all of our disciplines have been educated and trained on. We start with patient education and coaching interventions by the entire care team. The big focus again is on medication management and patient empowerment with self-management of their chronic disease processes. We coordinate care interventions with a specific focus on physician follow-up and engagement. And we also provided intra-episodic telephonic health coaching between our skilled visits. These phone calls reinforced what was actually done face-to-face with the patients in the discipline. Some lessons learned and some best practices throughout this that we felt that it was very important to communicate both to our team as well as the hospital facilities that we were working with is that our care transitions program does not replace hospital discharge planning. Both sides have to work collaboratively together. Care transitions occurs after the referral is made and the patient choice is still honored and they select their particular home care agency. It was very important for us to emphasize throughout the company with all disciplines that it is not just the responsibility of the care transition coordinator, but of the entire care team throughout the transition and the continued episode of care. Every role, every discipline has a role in care transitions. And care transitions is also important when the patient transfers directly from the physician. So if we don't begin care transitions with that in-facility face-to-face, we still start that health coaching model visit when we receive a referral from a physician office and the patient doesn't come from a facility. So how did we have a nationwide rollout? The next slide will share with you some of the infrastructure that we used to roll this out to the rest of our company. We had an area vice president of our operations and business development kickoff training on April 6th of this year. We had all of our line management attend the exact same training sessions that our field clinicians would need as they work through rolling out care transitions. Then we set up a rollout schedule by our vice president region that began on April 13th and continued through the end of August. We provided comprehensive 6-hour training sessions in each region. We had 2 offerings of each session, so the agency could send part of their staff one day and the other part the next day. Those training sessions included the Director of Office Operations, the DOO, the Care Transition Coordinators, formerly known as account managers, our rehab specialty directors, Again, that same line management that went through the initial kickoff training of our area vice presidents and vice presidents. And then we selected an RN field clinician or RN clinical manager that was going to be designated as a care transition coach, not so much for patients, but for the agency. A train-the-trainer champion type model that could go back and work with the field clinicians after they went through their initial intensive training. We provided pre- and post-discipline generic teleconferences to introduce the concept of care transition, and then the follow-up teleconference involved, do you know where your materials are, how are you doing with your classes, are there things that we can help troubleshoot with you, how's it working with your relationships with your facility. And then we created a CTIP package, very similar to the BPIP packages in the HHQI campaign. As you all know, a BPIP is Best Practice Implementation Package. So we created a care transition implementation package that had discipline-specific breakout materials where that RN clinical manager, RN field clinician that was the champion could actually sit down and say, what do therapists need to know about care transitions and what's important? What does a LPN or an RN need to know about care transitions? What does every role in that care center need to know to effectively implement care transition coordination? So as a result, the Amedisys Care Transition Model, we have effectively rolled out in 2010 to over 600 locations nationwide in a period of approximately 4 months. Our care transition coordinator visits the patients in the hospital after the home health referral has been received, and they guide the patient through the transitions from hospital to home. The focus in the home during the entire episode is on stabilizing the patient and teaching the patient self-management skills and techniques using a patient health coaching model. All aspects of the patient's life are worked on throughout their continuum of care within Amedisys. We don't just focus on the disease management, but we actually incorporate measures to promote an overall healthy and productive lifestyle. For example, we're not there to cure congestive heart failure. We're there to promote patient self-management of that chronic disease process that they are going to have to manage for the rest of their life. And we are a moment in time in their lives. So what can we do, and what are their barriers? Our key goals are to motivate our patients to become independent in monitoring and managing their own health status, provide the patients with the knowledge and practical skills needed to make informed decisions about their health care and improve their quality of life, and ultimately to reduce acute care hospitalization rates. A lot of the challenges that we heard from the field is that, well, we just have non-compliant patients. So we realized we had to really focus on teaching our disciplines to work with patients that they considered to be non-compliant. And the reality is that almost everyone wants to live a long and healthy life. And non-compliance usually means the patient doesn't have something. They have a lack of knowledge, a lack of understanding, a lack of confidence, or a lack of motivation. And when we empower them to remove those barriers from their life, then they become those compliant patients. Some other do's and don'ts and insights that we'll share with you of our coaching of our staff in working with these patients is praise and encourage your patients with each word and deed. Focus on personal goals for the patient. We're very familiar with writing goals on our care plan, but what is the patient's personal goal? We may want them to ambulate so many feet on community surfaces with a walker, and their goal might be they want to walk around their living room without falling and make their own coffee in the morning. That's a personal goal. So how do we get them there? Show confidence in your patients and family and be a resource, but not a crutch for the patient. Some don'ts that we learned is don't do things for the patient that they can do for themselves. Don't communicate for the patient. Don't show judgment or criticism. And don't let the patient see your doubts. They might have a personal goal that you might think is totally unreachable. You know, don't squelch that. Don't be negative about that. And don't let them see your doubts. And don't give up on your patients. So this is a slide just kind of sharing some of the do's and don'ts that we found with our staff. So we'd like to leave this webinar before we open it up with questions with a type of call to action. You know, care transitions is for the benefit of all of our patients. Our recommendation is to do what you can at your agency to begin implementing the model. Remember, we started with one facility, with one unit, with one diagnosis. We worked through all of the challenges and opportunities we had with that before we were able to refine it into a nationwide rollout. Do what you can with your physician network to engage in a dialogue about the power of care transitions. And if you're a hospitalist, encourage your administration to collaborate with home care agencies in your area to allow care transitions at your hospital. So thank you very much. With that, I'll turn the call back over to David.
Thank you very much, Tasha and Beverly. Just a really wonderful presentation, and I'm sure that there are a lot of folks out there that have questions. So we're at the point in our program that we're ready to for a Q&A period. Again, you can submit your questions by sending them to hhqi@wvmi.org. So at this point, we're going to turn the Q&A period over to Shannon. Shannon?
Thank you so much, Dave. We are going to start our questions with one from Penelope, who writes us from Nevada. Penelope asks, do you use a personal health record that is coordinated between other settings? She says that they would like to have a uniform personal health record that all providers give to patients.
That's a very good question. What we've seen with our health planner, if a patient has a health planner already in place, we don't try to replace it with ours. We use whatever works for that patient, and that might have been developed with another facility. We're finding more and more that as care transitions, more people are being educated on it, that sometimes we do run into that in certain regions where we have a facility that has started their own personal health planner for their patients or vice versa. So with that, we look to see if they have one at all, and if that's the case, we share that. We share what we're using with the facilities, so they are able to, so they know what that patient's health plan is going to look like when they come to us.
Our next question comes from Abby in North Carolina. Abby asks, this is actually for Beverly. She asks, Beverly, did you visit the patient in the hospital to start coaching before their discharge? And if so, how was that coordinated?
Actually, we do visit the patient in the hospital. Generally, what we have to have first is a referral for home health, and then from there, we will go in and start care transitions with the patient, and at that time, we give them the coaching booklet, talk to them about do they have a scale at home and what to expect for home health.
Okay, just a reminder, if those of you have questions out there, please submit them to hhqi@wvmi.org. Our next comment is from a Susan Rosenbeck at the Care Transitions Program at UC Denver, and it's more of a comment than a question, but Susan tells us that organizations interested in adopting the Coleman Care Transition Intervention can contact her directly regarding planning for adoption of the model and training of the transitions coaches. And Susan Rosenbeck's contact information, her office telephone number is 608-831-2365, and her email address is susan.rosenbeck, that's R-O-S-E-N-B-E-K, at ucdenver.edu. And in case you didn't have a chance to write down that contact information, we will repeat it later on in today's session. Moving on to our next question, this one comes from Annabelle, who asks, good information on purchasing scales in your presentation. Who did you say funded the purchase, and who was on the committee to decide on which scales to purchase?
Yes, this is Beverly. Not-for-profit foundation was formed at Gwinnett Hospital, and they actually purchased the scales. The patients are actually triaged to see if they have the financial ability to afford a scale. The social workers at the hospital take care of that, and then they go and actually pick it up with a voucher for the patient.
Okay, our next question comes from Ollie. Ollie asks, he says, I think Beverly mentioned a readmission rate. He said he thought you said 27%, and Tasha showed the ACH rate. How did you calculate the readmission rate, and how is this different than the ACH rate?
Beverly and I will both take this one. The rate that she was talking about, the 22% readmission rate in 30 days, was the Gwinnett Hospital readmission rate for CHF patients. The hospitalization rate that I mentioned in my slide, the one that is measured on www.medicare.com that has the home health compare hospitalization rate. So that's home health rate is the one that I shared, which went from 32.8% to 31.8%. The statistic that Beverly shared is actually the Gwinnett readmit rate in 30 days. Is that correct, Beverly?
That's correct.
Thank you.
Next, we hear from Debbie in the Empire State of New York, who asks for any ideas for strategies for home health to initiate a dialogue with hospitals. For example, who should be the first contact? How would you recommend getting the conversation going, et cetera?
I would start with first identifying their highest DRG. It may not be congestive heart failure like we found out at Gwinnett Hospital, but first research that. Start with your discharge planning team, and then from there, just make appointments to talk about what your care transition will be, what the rollout can be, and how it benefits the hospital and their patients.
Next, Sally writes and asks, what type of physician orders are used to provide health coaching? What source of payment is available if we're not a QIO, just a small Medicare home health agency?
I'll take that one. This is Tasha. Health coaching falls under the Medicare skill of teaching and training. It's the method in which you teach instead of at the patient or instructing the patient that you're empowering them through that instruction. So don't misunderstand, every one of these patients still meets to meet the Medicare criteria for home care services of intermittent skilled care. One of those skills is teaching and training, and the health coaching model folds underneath that. They still have to meet all of the teaching and training. So what we find in a health coach intervention is that that patient has some knowledge deficit related to how they can self-manage their disease process. So you still have to have the documentation, you still have to meet all the Medicare criteria, but that's where the focus is.
Next question is from Judy, who asks, what is the length of stay at Gwinnett? Is there enough time to educate the patient while hospitalized?
Well, our classes do begin at the hospital, so that's one of the things at Gwinnett that they saw that was very necessary to start educating the patients once they come into the hospital. There is sufficient time. Usually we get probably a 48-hour notice with home health to start educating that patient on what to expect after hospital discharge.
Our next question is from our friend Barbara in Nevada. She actually has a two-part question. The first part is, can you clarify what RSD stands for on slide 21? And the second part is, do you have a linked electronic medical record between your home health and hospital settings?
The first, RSD, is our rehab specialty directors. We have about 150 to 200 of them nationwide that basically rehab directors over a team of our physical, occupational, and speech therapists. The second question is, do we have an integrated electronic health record from us to the hospital? And no, we do not at this time. So we don't have anything integrated.
Next, Judith asks, do you think that the use of the Coaching Model Care Transitions program is more successful than home health agencies using home telehealth monitoring equipment?
Actually, we incorporate in many of our sites the telehealth monitoring equipment into that model. And with our, in some areas we have a centralized telemonitoring station, and we teach them health coaching techniques as well. So what, if you'll notice on one of the implementation slides, not only do we have the face-to-face visits and the start with the care transition coordinator, but one of the most effective things that we also found was the in-between visit telephonic health coaching that actually can be done quite well with using telemonitoring equipment. So depending on the patient and some of our markets, we actually have all of that going on.
Liz asks, this is for you, Tasha, what does the slide mean, quote, don't give your families a break?
Well, don't give your families a break, meaning, you know, oh, I don't feel like managing the medications today, or I don't feel like doing something that's a part of their self-management of their disease process, and say, don't worry about that, I'll handle it for you. Because often as caregivers, we enable the patient and the caregiver, the patient's caregiver, instead of empowering them. So that's what don't give them a break means. It means, you know, don't create a codependent type situation, because that's not really what we're there for.
Next, Annette has a three-part question from Oklahoma. I'll take these one at a time to make it easier on you all to answer. We'll start with part one. The question is, did Amedisys roll this out in every state?
Yes, we did.
Okay. And
that we have markets in.
Well, the follow-up question may be answered by number one, but she asks, did your Oklahoma offices implement this process?
Yeah, our agencies, because depending on where they were at in the rollout process, may be still in some various stages of some of that continued education, but they're pretty much all rolled out in every location.
Okay, and the third part of her question, I should note that she's the executive director of the Oklahoma Association for Home Care, and she says, our board of directors implemented a care transitions committee in January 2010 in anticipation of the QIO 10th scope of work requiring all states to implement this process. Our Home Care Association would like to take the lead on this in our state. What recommendations would you have to make this happen on a statewide level with all of our members included?
Well, first of all, my email is certainly listed up there currently right now if we want to have a further offline discussion on that. One of the biggest successes that we see in different areas as we've rolled this out company-wide is that getting all of the stakeholders together at the table, we were there with our competitors, and we created a community of continuum of care. So get all of the stakeholders at the table. A good example was a patient actually went to an ALS facility. They weren't initially sitting at the table when we were discussing the patients. We had hospitalization occur associated with an ALS. The next week, the ALS was sitting at the table. So the biggest strategy I would tell you is to get all the stakeholders together, to work together as a community for the benefit of the patient. But I would be happy to have a more lengthy discussion. I'm very excited, and we'd love to support whatever you're working on in your state to see if we can be
Okay, our next question is from Anne Marie in Massachusetts, who asks if your CTIP packets are available to view or purchase.
That's a great question. I don't know the answer to that, to be perfectly honest with you. Right now, it's proprietary information. If she wants to send me an email, I have my email listed up here. Perhaps we can discuss that further.
Next, we go to Jacqueline, who asks, are you saying that an additional staff member would function as the health coach in addition to the home health case manager?
No, let me explain what I can see where that slide might have been a bit confusing. So the roles that we have in this is our care transition coordinator that does the in-facility start of the health coaching model, the actual discipline seeing the patient that are providing a skill under the Medicare benefit are trained on health coaching. What we did to roll this out to so many different clinicians was we created a train-the-trainer model. So we created an RN clinical manager, or the DOO got to select somebody to come to the extensive on-site training and then go back and help train the rest of the staff in the rollout. So that's what the role of that care transition agency coach was to go back and coach the agency on health coaching. How do we get everybody on the same page, treating the patients the same way, and everybody working together?
Next, Grace in California says, I read about the Bridge to Healthy Living book in one of the HHQI Best Practice Intervention packages. Is this something that your company uses, and do you know if it's available for others to use?
Actually, it is copyrighted. It is our proprietary book. We took a lot of things that we have learned from multiple different planners, multiple different coaching models, and after extensively using what worked and didn't work in our project with the Georgia QIO. So it is actually proprietary. There are a lot of resources out there, though, and I'm glad they talked about Dr. Eric Coleman with their types of personal planners. I believe his might be available for purchase.
Okay, and just a reminder as well, that preview and that information is available in the latest Best Practice Intervention package, which is called Cross Settings 1. This is all about care transitions. It's available to all Home Health Quality Improvement National Campaign members at homehealthquality.org, same website where you registered for today's session. So if you're a participant and you have not yet downloaded this BPIP, please take a chance to do so as soon as this webinar is over. And if you're not a participant in the campaign yet, just take the 5 minutes it takes to sign up, and then you too will have access to this Cross Settings 1 Best Practice Intervention package all about care transitions in there. And moving on to the next question, we go to Allison, who says, did you say that you use the same patient education information as the hospital? That would be super. Just wondering how you did that.
Well, I'll let Beverly take. Yes, we did. We did actually share our teaching materials, and they shared theirs. So, Beverly?
Well, what we basically did, as we met as a committee, we compared all of our data, all home health providers, because what we wanted to make sure that every patient, no matter what home care agency they were going to be assigned to or choice of, that they will all receive the same information. So yes, we did share a lot of the information with our local hospital.
Okay, moving on to our next question. Let's see, we've already addressed that one. Let's move on to another one. This one comes to us from Brenda, who asks, does your care transitions coordinator do both the hospital and home visits?
No, the care transition coordinators are usually assigned to facilities like the hospital, assisted living facility, nursing homes, and personal care homes, but we are not doing home visits.
Okay, this next one comes from Naomi in Pennsylvania, and Naomi says, please address if you've had barriers getting physician buy-in, 1, to schedule follow-up appointments, and 2, to increase the home health referral from physicians.
I'll take that. This is Tasha. In some areas, we have had some challenges with that, of actually trying to get, physician offices. Some practices are extremely busy, and trying to get the patient back even just in the first 30 days can be somewhat of a challenge. We try to identify on the front end what those challenges might be and try to work through a multidisciplinary team, whether it's our social services team, our account executives that actually go out and educate our physician population for that. So we take it as an opportunity to get in front of the physician. And when we do that, we usually come with patient-specific information. So it's not really a sales call. We're updating the physician on their patients that are very specific. And they usually often appreciate that. They understand the buy-in of that. We've also leveraged our medical director sometimes to actually, if we have a particular challenge getting some patients back into a certain physician, we've had our medical directors actually work with those primary care physicians, not in replace of, but work with doctor to doctor to kind of overcome some of those challenges.
The next question comes from sunny Miami, Florida. It's from Angela, who asks, How do the disciplines communicate or schedule visits, or does the coordinator only make home visits?
The care transition coordinator, and this is the part of with all the models that we looked at, you know, Mary Naylor's model, you had the nurse practitioner that did both the in-facility, went with the patient to the doctor, and was the same one making the home visits. We had to look closely as an organization and go, we don't know that that would be feasible and scalable for us to do that. So the care transition coordinator does that care transitions from the inpatient facility face-to-face and starts that process. That's why we were so intent on training everybody the same way, no matter what your discipline was. And then they actually communicate with that primary nurse or that care center leadership or clinical manager about and report off on that patient. So that way when that nurse or registered physical therapist that opens that case has a really good handle on what that patient and report off on that patient so they can continue what was started in the facility throughout the episode of care. We require multidisciplinary care team conferences on a weekly basis where patients are discussed.
Next, Deborah asks, if your agency is not part of a hospital system, how do you suggest a freestanding home health agency gets a good start with the local hospital?
I would really start with the physicians to let them know your transitions, because actually those are the people that are actually going to start your home health referral. Start with your physicians, your assisted living facilities, nursing homes, just educating them about care transition, how patients manage themselves, and the goals of the entire program. So that's where I would start at that point.
Next question's from James, who asks, is it possible to give a ballpark approximate cost to an agency for implementation of the general plan?
Well, you saw on the slide that we did the 6 hours of training from that component, so you would probably take those administrative rates and the time it took to train everybody. Then we had follow-up competency checks associated with that. So whatever, you know, I don't know what your rates or how you pay from that perspective. And then the cost of printing the personal health planners in color, or you may choose to do black and white. You might choose to do something a little bit different. That's an option as well. And then, of course, you have the cost when we created our CTIP package, which, you know, the printing costs of those would be just defined as, and they're about 2 inches thick, so they're pretty expensive. If you've ever downloaded a BPIP package, you kind of know how expensive those can be, so ours was very similar to that. So those are really the costs that are associated with the implementation of the plan.
Next, Kurt in Orange, California asks, what drug information sources do you use for coaching? Do you partner with pharmacists to provide education, and do pharmacists participate in these programs?
Actually, we do use the Medispan drug database in our system that has some drug-to-drug interactions once all the medications are loaded into our system that we start with. In different markets, we have some local relationships with pharmacists. You know, our role in home care, we are the ultimate reconcilers of medications. We're the ones that are looking on top of the refrigerator, in the bathroom cabinet, on the side of the bed, putting everything together. And at that time, coordinating with the pharmacist or the multiple physicians that patient sees to ensure that we have a solid medication list for that patient to manage by.
Kathy in Illinois asks, are your care transitions coordinators all nurses? Do you have social workers on your transitions teams?
Actually, out of about 500 approximate care transition coordinators that we have, all are nurses but a couple, and those are social workers. So, and they were we typically hire nursing into this, although certainly the ones that we have that are doing a great job for us as well. But they typically are nurses, RNs.
Next we go to Vicki, who says, I'm concerned that coaching will replace home health visits. I see a home health visit as a coaching visit. What are your thoughts on this?
Well, actually, the home health visit is the coaching visit. It definitely is. So it happens throughout in different, we've seen different utilization patterns in certain areas with telephonic health coaching in between the visits. Sometimes we've seen changes in that, and sometimes it has stayed the same. So coaching occurs at multiple levels. It occurs with the care transition coordinator starting the process, the field clinician actually seeing the patient face-to-face, and then between those visits, telephonic inter-episodic health coaching as well.
Katrina in Florida says, I like the information about setting up the doctor's visit within 1 week. I've read that this is important. Doesn't the hospital schedule this on discharge? Does your agency follow up to make sure it's scheduled?
The study at Gwinnett Hospital, the cardiologist decided that those patients needed 1 week follow-up. Generally, the hospital nurses help us with that process, but after the patient's admitted to our services, our staff usually confirms they do have a follow-up appointment with a physician and when that appointment will be, and then we will do a visit after that patient has seen their physician.
Next, Pat asks, what was your relationship with the hospital before this project? How did you get their buy-in without being a threat to them?
Well, what we first did again is look at their DRG, which is the congestive heart failure. And you have to present it to them as to what the benefit is going to be for them to decrease their readmission rate, as well as to help and challenge that patient to do the things in order to manage their health. That way you come across as being a facilitator to help them decrease their readmission rate and also help those patients help themselves.
Rebecca asks, did you utilize any other patient teaching education materials aside from your Bridge to Healthy Living?
Yes, actually we did. We have our Heart at Home disease management program that has clinical tracks and patient education guidelines in there. So, you know, again, health coaching is teaching in a way. It's just the method in which you deliver that teaching and that understanding and empowering the patient rather than enabling them. So we did use our other materials.
Next question is for Tasha. Molly asks, have you seen an increase in referrals since you have worked with the providers more closely, especially as they see the positives with better care to the patients? Our problem is getting an audience with other providers, especially physicians.
You know, we really haven't tracked that information at this point in time to be able to provide that to say, you know, we've had an influx in that information. So honestly, we haven't done this to increase our referral base. We've done it for the quality care of the patient. So I really don't have that information to share. I'm sorry at this time.
Bridget asks, what do you do with patients who do not have a primary care physician?
Well, we try to assist them in choosing one. You know, we don't steer them in any way. We try to make sure that they have some opportunities for that. We try to coordinate between the physicians that have them. Sometimes a hospitalist will ask that patient, you know, do you have a primary care? If not, you know, here's your options and look at them. So we try to create a team effort on that.
Melanie in North Carolina asks, did all of your care managers become care transitions coordinators, or do you have both care managers and care transitions coordinators at your agency? If you have care managers, still, what role do they play in this process?
We are account managers, which focus primarily on referral intake processing, are the ones that became care transition coordinators with this rollout and additional education. Our agencies have our director of office operations, and then we have what we call clinical managers that manage a team of patients. that may be where some of the confusion comes into play. So again, our account managers that were basically more of an intake referral component, we've now basically had them evolve into care transition coordinators with this additional training.
Jan asks, how are you handling medication reconciliation when the patient's discharged with a hospitalist and their primary care provider does not have hospital information and the patient does not want to follow discharge medications?
Well, I think we have a huge opportunity when that happens, and it happens a lot. We get that list from the hospital, we're in the home, and home health has the opportunity to be the best medication reconcilers that are out there. And, you know, that admission visit takes sometimes 2 hours, and we get the basket of pills that are sitting, you know, on top of the refrigerator. We get the grocery bag from their end table at their bedside, and we are the Sherlock Holmes in the home. Show me everything you've got that you've ever taken at this point, pull it all together, reconcile that, and then work with the physician, primarily the primary care physician, to say, who may or may not even be aware sometimes if they're a patient within the hospital or what medication changes are. So we're that conduit between that hospitalist that might have sent home one medication regime and then really it may not even come close to matching what the patient was previously taking or what they want, the primary care physician wants the patient to follow with. So we provide that information and try to get orders to, you know, change that to the appropriate medication regimen.
Next, Olivia starts by thanking both of you so much for this presentation. She indicates that it was very helpful to her and her staff in Pennsylvania. What she'd like to know is a little bit more about any issues within the committee that Beverly talked about. She'd like to know what were the big issues you had to overcome, and was everyone on the same page?
What we found throughout the year and a half that we met as a committee, there were always some challenges. We always identified a problem and we moved to the next step. One thing about the committee, it was hospital personnel, home health, and physicians. So as problems arose in the committee, we always came back to the table and said, let's work on this process. Understand that we didn't figure all of this out overnight, particularly with the scales. It was just something that came up in a meeting. How do we know that our patients are weighing themselves every day? The classes from the hospital evolved from us asking those key questions in the committee meetings so that we could move our program forward to help our patients.
Next, Katie asks, who specifically makes the telephonic contact with the patient between visits?
Well, that can be in a variety of different ways. We have an Encore Disease Management call center that we leveraged for that particular beta. We also, we brought in a focus group probably about a year or two ago looking at reducing hospitalization rates. One of the common denominators that we found for our agencies that were the most successful, they had that telephonic outreach with their patients periodically between visits, whether that was a staff member in the office, whether that was their care transition coordinator, whether it was just even the primary care nurse seeing the patient that called back later between visits. So we've got a number of different models that are out there that we use for that telephonic health coaching.
Next, we actually have a comment from Mary, who's with the Georgia Quality Improvement Organization, and she asked us to please announce that a personal health record can be downloaded from the Georgia QIO website and can be adapted for your individual agency regardless of where you are in the nation. The web address for their website is www.gmcf.org, and she says to click on the Care Transitions page. If you're interested, I've also chat blasted that message to all of you on the line today. So look in your chat windows under the WebEx feature, and you can find that web address. And in that window, I've also provided the contact information from earlier about getting additional care transition tools. Our next question comes to us from Patricia, and Patricia asks, are you also using daily telemonitoring for heart failure patients?
In some of our markets we are. In some of our markets we do have telemonitoring units deployed. We don't have them nationwide, although we've had a big push this year to increase the number of agencies that we have that have telemonitoring units. So in some of our markets we do, probably about half of our markets we have telemonitoring right now.
Okay, our next question comes to us from Margaret, who asks, are you providing transition coaching for patients who are not eligible for home care or they may not be homebound?
You know, not at this time. We certainly aren't. All of our patients have to meet what that Medicare or payer criteria is for home health services. So no, we aren't currently. We don't have a retail model around that right now.
Katie in Georgia asks, does the hospital care transitions coach that starts the process speak to the RN or physical therapist to coordinate the care of the patient?
Yes, actually they do. They make that transition back to that care center, and it's either with the person that's actually going to be seeing the patient, or it might be the clinical manager that's at the office. So they do. They communicate that information back to the people that are actually going to be the boots on the ground taking care of the patient.
Judith in Washington, New Jersey asks, do you think that the Presented Care Transitions Model Program was and will continue to be successful than home health agencies using home telehealth monitoring equipment in order to reduce ACH readmission rates?
You know, I think that different things, I don't think it should replace. I think that it should augment, and that each patient and market is individual, and they need to determine what combination of best practice interventions works best for a particular type of patient or a particular model. Again, as I mentioned before, you know, you can incorporate some health coaching components into that interaction with your telemonitoring models. So what we found is, you know, some patients are appropriate for telemonitoring, some are not. But in any instance, we know that we need to work on health coaching for that patient.
We'd like to thank you all for such great questions today. We have time for two more before we wrap up. This question comes from Sharon, who asks, how did the nurses adjust to using the new coaching model? And do these agencies use a patient satisfaction tool? And did they see a decline in not helping families?
Okay, well, first, with the nurses and that, actually, their buy-in was great. Another thing I probably should have mentioned is we had a contest for success stories, and that helped with the buy-in of the nurses, of actually, you know, send us in your clinical success story for a patient that you implemented this coaching model on and what the impact of that was, and really created some positive buzz around it. They really appreciated the education and the investment in their time and things like that. So they actually responded quite well. Patient satisfaction, we have not seen any change in our patient satisfaction results as a result of this component. So, but we certainly are going to be watching that. We recently implemented our CAP survey, so that's pretty standardized.
And our final question for today comes from Linda in Kentucky. And Linda writes and says, hi, Beverly and Tasha, thank you so much for the presentation. I really enjoyed it. She says, it sounds like you had buy-in for the Care Transitions program from your leadership. What would you suggest for someone who doesn't have that buy-in? Are there resources on why Care Transitions is important that I could share with my leadership to convince them of its importance?
Wow, but you are absolutely right. We had buy-in from the top down, from every level of this organization. We really did. One of the things that helped with that buy-in is all of Beverly's hard work at Gwinnett and with the Georgia QIO and that team together. So I want to send some accolades out to the facility as well as the Georgia QIO assisting us in doing that. And we really proved the benefits. That helps with leadership buy-in. So significantly. Now, there's a lot of resources out there on care transitions. I think they mentioned some of those, but Dr. Eric Coleman's work, Dr. Mary Naylor's work that's out there, and reaching out to the different quality improvement organizations that are out there. You now have the website, the one that we worked with in Georgia. They have a lot of really good care transition information. I believe there's a website on caretransitions.org as well. So there are a lot of research and everything that's out there, but to make it very simple, you can implement this one patient at a time. Try it with one patient. Show the success, and it will spread like wildfire.
Thank you so much, Tasha, and thank you, Beverly, for fielding our questions, and thank you to all of our participants for a great interactive session. I'm now going to turn things back over to Dr. David Winter for today's closing remarks. Dave?
Thanks, Shannon. And again, I'd like to echo Shannon's thoughts on behalf of the rest of the Home Health National campaign team and all of the participants today. We really want to thank Tasha and Beverly for really an outstanding, very informative and valuable presentation. And I'm sure that this is going to create many ideas and thoughts in terms of within other home care agencies about this model. Again, we'd like to encourage all the participants on the call today to visit our website for the national campaign, and again, that is www.homehealthquality.org. Also, as a reminder, today's webinar is being taped and will be archived on our website to be able to be downloaded and shared with those unable to attend today's webinar. We are in the process of planning our next webinar, and given the upcoming holidays, we're going to try to schedule this for sometime in early to mid-January. The topic that I'm working on right now will be the sharing of how a large hospitalist group was able to enhance their discharge process by improving communication across care settings with the inclusion of home health referral and the communication then downstream to the primary care physician. I'm going to ask them to describe their best practices and some of the obstacles and hurdles that I'm sure we can all imagine that they must have had to overcome in order to implement this process. Please check out our website for further pre-registration instructions for this webinar. And again, I'd be looking for that information sometime toward the beginning or middle of December. Again, thank you for all of your participation and great questions, and we hope that you have a great rest of your day.